Today we are talking about diabetes mellitus in dogs and cats. Diabetes mellitus is a chronic disorder of carbohydrate, fat, and protein metabolism caused by inadequate insulin secretion, impaired insulin action, or both. The classic signs are polyuria, polydipsia, polyphagia, and weight loss. When blood glucose rises above the renal threshold, roughly 180 to 220 mg per deciliter in dogs and 250 to 300 in cats, glucose spills into urine. That glucose draws water with it, causing osmotic diuresis, dehydration, and excessive thirst. The pathogenesis differs between species. Most diabetic dogs have severe, usually irreversible beta cell loss and therefore resemble an insulin-dependent state. Pancreatitis, immune-mediated injury, genetics, hyperadrenocorticism, obesity, glucocorticoids, and progesterone-driven insulin resistance during diestrus can contribute. In cats, disease more closely resembles human type 2 diabetes. Obesity and other insulin-resistant states increase insulin demand, beta cells initially compensate, then glucose toxicity, islet amyloid deposition, and beta cell dysfunction reduce insulin secretion. Because feline beta cells may recover when glucose toxicity is rapidly controlled, some cats can enter remission. Diabetic dogs usually require lifelong insulin. Insulin deficiency prevents efficient glucose uptake by skeletal muscle and adipose tissue while removing insulin's restraint on hepatic gluconeogenesis, glycogenolysis, lipolysis, and ketogenesis. The result is hyperglycemia despite cellular energy deprivation. Fat breakdown increases free fatty acids, which the liver converts to ketone bodies. If ketones accumulate with dehydration, electrolyte loss, and metabolic acidosis, diabetic ketoacidosis develops. Vomiting, anorexia, weakness, dehydration, or altered mentation in a diabetic patient is an emergency. There is no single standalone laboratory gold standard. The clinical gold standard is the combination of compatible signs, sustained hyperglycemia, and glucosuria. In dogs, fasting glucose repeatedly above about 200 mg per deciliter with glucosuria is strongly diagnostic. Cats require more caution because stress can cause transient hyperglycemia. A cat should have evidence of sustained hyperglycemia, such as increased fructosamine, repeated hyperglycemia, or glucosuria at home, or compatible continuous glucose monitor data. Fructosamine reflects average glycemia over the previous 7 to 10 days, but reference intervals vary and values may be falsely lower with hyperthyroidism or protein-losing disease. Additional testing should include a complete blood count, serum chemistry with electrolytes, cholesterol and triglycerides, urinalysis with sediment examination, and often urine culture. Cats should usually have total T4 measured. Evaluate dogs for pancreatitis, hyperadrenocorticism, diestrus, and other causes of insulin resistance. Measure blood beta-hydroxybutyrate or urine ketones in any sick patient. In cats, beta-hydroxybutyrate above 1.0 millimole per liter indicates ketosis and warrants closer assessment for ketoacidosis. Treatment aims to stop clinical signs, maintain body weight, keep glucose below the renal threshold for much of the day, and avoid hypoglycemia. In dogs, insulin is required. A common first choice is porcine lente insulin at approximately 0.25 units per kilogram every 12 hours, adjusted by the veterinarian. In cats, common starting options are Glargine U100 or protamine zinc insulin at about 1 unit per cat every 12 hours. Insulin binds its receptor tyrosine kinase, promotes GLUT4 movement to the cell membrane in muscle and fat, increases glucose uptake and storage, and suppresses hepatic glucose production, lipolysis, and ketone formation. Selected newly diagnosed cats may qualify for an oral SGLT2 inhibitor such as bexigliflozin or vilogliflozin. These drugs block sodium glucose cotransporter 2 in the proximal renal tubule, reducing glucose reabsorption and increasing urinary glucose loss independently of insulin. They are not appropriate for every cat and require careful screening and blood ketone monitoring because euglycemic ketoacidosis can occur even when blood glucose is below 250 mg per deciliter. Sick, ketotic, previously insulin-treated, or otherwise unsuitable cats generally need insulin. Nutrition and monitoring are essential. Feed dogs a balanced diet in consistent amounts at consistent times. Increased fiber may help some dogs. Cats often benefit from a high-protein, reduced carbohydrate diet, below about 12 to 15% of metabolizable energy from carbohydrate, while avoiding rapid weight loss. Home glucose monitoring or a continuous glucose monitor is preferred when practical. Insulin doses must never be increased from one isolated glucose value. Weakness, tremors, disorientation, seizures may indicate hypoglycemia and require immediate veterinary instructions. Prevention is not absolute, but risk can be reduced. Maintain a lean body condition, encourage regular activity, treat pancreatitis and endocrine disease, avoid unnecessary glucocorticoids or progestins, and spay intact diabetic female dogs to remove progesterone-related insulin resistance. In overweight cats, weight loss and environmental enrichment improve insulin sensitivity. Early recognition of increased thirst, urination, appetite, or unexplained weight loss allows treatment before severe dehydration or ketoacidosis develops. If you have topics you would like to suggest or donate to our video and game development, reach out to dogtoursgame@gmail.com.